shaping the future of self-care through pharmacy. So my name is Emma Paulino. I am the FIP Professional Secretary and a member of the Executive Committee and the Bureau. I am former Secretary of the FIP Community Pharmacy section. I'm a community pharmacist myself, so obviously this topic in particular is very important for my day-to-day activities. I'm currently president of the National Pharmacy Association in Portugal and of the Pharmaceutical Care Network Europe. And it is my pleasure to be talking to you today and moderating this webinar and also leading the panel discussion later on. So in the next slide, there are some announcements. So for your information, this webinar is being recorded and it's also being live streamed via YouTube. The recording will be available on our website, and this is the link to the website where the webinar will be made available. So the slides themselves will not be available, but you will be able to access the recording of the event. You may ask questions and you should do so by using the question box provided. You can also use the chat box to introduce yourself, but we kindly ask you that if you have questions for the panelists, that you use the specific Q&A box section, which you may find below on your Zoom app. You are welcome to also provide feedback to webinars at fip.org. Through your feedback, we obviously can improve for following events. And of course, you can and should also become a member of FIP at www.fip.org, membership_registration. And through this link, you will also get more information about all the benefits you get from being a member of FIP. So we would like to thank Reckitt for supporting this online program. Thank you very much. And it is due to this support that we are able to provide all these interesting resources for community pharmacists around the world and those that would like to support self-care and in particular empower patients to take better care of themselves. So thank you very much, Reckitt, for allowing us to provide this continuing education program to our participants. So for today's program, we will have 3 speakers. I will introduce them shortly. They will talk about the topic on women's health and self-care in general. And then we will have a panel discussion with questions and answers. And you will be able to, as we progress in the webinar, you can include your questions and I will take those afterwards and introduce them in this final decision. Then we will have a summary and close, and we plan 1 hour and a few minutes for our event. For our learning objectives, we aim to increase awareness of women's health issues, how common they are, what impacts they can have, and how they can be managed. We also aim to describe how to support women with their common health issues across their life course, and discuss appropriate management in the choice of medicines and products. So these are our learning objectives for today. Our target audience are healthcare professionals, particularly the pharmacy team who support people to self-care. And I'm very happy to introduce our first speaker for today, Nausea Mayema. And she will talk about how can the pharmacy team support women's health in this episode. I will briefly introduce Nausea. She's a pharmacist who is passionate about women and health. She studied B.Pharm and M.Pharm in South Africa and further completed a Master of Science in International Development, Governance and State Building from the University of Birmingham, United Kingdom. She is a Women Deliver Fellow. Amongst other leadership roles, she was the president of the Junior Public Health Association of South Africa and served in the board of Public Health Association of Africa. As an advocate for health and women's rights, she enjoys using her skills in development together with those in health. She has been involved in policy development and consultation for organizations such as the African Union. Nsovo was named as one of the 200 male and guardian influential young South Africans in 2016 for her work in gender and healthcare. She's currently teaching while doing community development work. Thank you very much, Nsovo, for accepting our invitation, and you have the floor. Thank you.
Thank you so much, Emma. Thanks for the great introduction. So we're going to discuss how the pharmacy team can support women's health and also promote self-care in general for women. But you would ask yourself, why would we promote self-care amongst women? And why would women be interested in self-care? Well, initially, or in the first place, we want to prevent disease. And also the women that we are speaking about would like to prevent disease because they would like to live a fulfilled life and they want their life to be whole. But then while they're living that fulfilled life, you want to extend it longer because women and people in general want to live longer. So when women live longer, then at least there is a benefit to society. There is a benefit to the people that care for them and also those that they care for. And then you would further ask yourself, what issues are women dealing with? Women are currently dealing with a lot of issues. I mean, amongst them, we've got COVID-19, and COVID-19 has got a lot of, I would say that it's got a lot of guidelines on how to do self-care. We've seen how everyone is now taking, everyone now wants to understand what is it to build immunity or to strengthen immunity. And that is because of the COVID-19 hype that we're dealing with right now. So when you look at the instance of self-care, it plays a very large role in terms of prevention. We want to prevent conditions such as obesity. We want to prevent gender-based violence. Women go through pregnancy. They go through respiratory diseases. They go through multiple issues like mental health issues, and they want to remain healthy and they want to live long. But one of the things that would prevent women from actually engaging fully in self-care is actually the status that women are in different parts of the world. So when you look at the status of women currently, we've got women that are they deal with multiple issues, and how much they can engage in self-care largely depends on which resources are available to them. So resources can include time. Women do struggle with time because they work. If they're not working, that is paid work, they do paid work. If they're not doing paid work, then they're doing unpaid work, that is caring for the family, running the household, and so on. Furthermore, there's a resource like money. If money is available, then it means that a woman is more likely to have access to self-care. But then if there's no money available, then it causes a limitation. Then we've got the general freedoms. So freedoms would be expressed in different ways, where certain women have got particular freedoms and certain women wouldn't have. The freedoms would be limited by religion. They can be limited by social determinants of health, by where they are located, which part of the world they're living. And then there's the privileges, the general privileges of being born. A woman that is born in a war-torn country, for example, will not have the same privileges that will allow them to access self-care or engage in self-care like those that would, like a woman that is born in a stable country. And then the healthcare system as well, the structuring of the healthcare system of where the woman would be located, that really matters in determining whether the woman would engage in self-care or not. Furthermore, on the status of women, gender itself plays a role. So by the mere fact that a woman is born a woman, that would limit, for example, their ability to engage in self-care concerning HIV/AIDS. Because as you would know, that women are more likely to be infected with HIV or AIDS unsolicited than men. Furthermore, women are carers, and also they are providers in some cases. Currently, the International Labour Organization reports that women make up 38.8% of the labor force. So the women that are part of the labor force are also the women that are doing the caring work. Hence, we can see that there is more of a burden for women to have that available time for them to engage in self-care. In terms of the social cultural factors that affect women's health, there is poverty. Women have to deal with poverty in a lot of ways. There's poverty in poverty, for example, in starting from adolescence. When women go through menstruation and so on, there's period poverty. We've got unequal power relations that exist between men and women, and that could be accentuated by the different locations or different countries where the women would be located. We've got social norms that would decrease the opportunities that women would have to education and also paid employment. There is a focus in large parts of the world where where there's a large focus on women being more reproductive than actually doing other work or contributing to the economic structure of different countries. And furthermore, women experience abuse. It could be physical, it could be sexual, it could be emotional. And so, as such, we have got a role to identify these needs that women have got within society itself. In terms of reproductive and maternal health, we've got 40% of pregnant women are currently anemic. UN Women reports that 810 women die every day of preventable causes that are related to maternal health and also childbirth. We have got there was an estimated 295,000 women that died of maternal causes in 2017, and also more of cervical cancer. Well, women are one of the leading causes of diseases amongst women in the United States is reported to be heart disease. And there's 59%, there are more HIV infections amongst young women and adolescents. And women are more likely to show signs of depression and anxiety than men. And also, the effects of sexually transmitted diseases can be more serious in women than men. Furthermore, osteoarthritis affects more women, and also women are more likely to have urinary tract problems. So from the statistics that I've just spoken about now, clearly you can see that women are dealing with all of these conditions, and all of them are preventable through self-care. So if women do have the support, these statistics would actually look different. That is the reason why you would need a pharmacist to intervene. And you may want to ask me, what ways would a pharmacist intervene, or what would the role of a pharmacist be in such a case when we're dealing with such statistics that women are going through in different parts of the world, which is not limited to particular countries as in developed and the developing countries. So the role of a pharmacist, I would place it in 4 ways. That number one, we have a role in managing medicines. We have a role in prevention. We have a role to provide information and advice. we have a role in providing psychosocial support. So these dimensions are based on the role that is under the 8-star pharmacist that I like teaching my students about. When we come to medicine management, we have a role to monitor and alter the prescriptions where necessary. So women come into the community pharmacy with prescriptions, trusting that their doctors have prescribed what will be best for them. And you as the pharmacist will provide the prescription or will make up the prescription and provide information that is necessary. So when you're a pharmacist in a community pharmacy, especially when you're dealing with women, remember that the women have got traumas that they suffer from. They've got untold stories that they cannot really share with you. And women are vulnerable in nature. So when you are making up a prescription, it's very important to make sure that in terms of your medicine management, you monitor and you alter it appropriately. And furthermore, you open up to the patient, you ask questions, and you detect any form of trauma that the woman may be suffering from. You educate the patient about the most common mistakes that patients engage in. And that is for women especially. Women usually have got a lot of questions, especially in a pharmacy, and not all of them are particularly vocal about the questions that they have or the concerns that they would have. So it's your role as a pharmacist to open up and try and check, how can I assist? How can I make the patient open up more? And how can I provide the support? In terms of prevention, the different strategies which need to be, in terms of prevention, there are different strategies that would need to be implemented. And prevention strategies would need to be context specific. Christopher? Thank you. Prevention strategies would need to be context specific. So when you are looking at prevention, you need to consider the age of the women that you are engaging with. You need to consider the location. I mean, in terms of location, what you are free to speak about when it comes to menstrual health, for example, what you would be free to speak about in a country that is largely religious would be different to a country or a location that is secular. Same would apply to a rural location or an urban location. You would need to consider availability of resources as well. If you are going to speak to women that have got resource limitations, then you would need to adapt it to that. And you would also need to consider your goals as well. One of the best tools to use when it comes to prevention is health promotion in general. So you need to promote health within the community pharmacy that you're located in, or within the community by doing campaigns and so on. And you need to consider the specific health needs. For example, when you're dealing with transgender women, their needs will not be the same as the, I would say, would not be the same as an older woman. So you would need to look at, for example, with transgender women, they need to take hormonal treatment. So when you're doing health promotion campaigns for the care community, for example, you would need to make it adaptable for them. Same applies to adolescent health, the language in which you communicate with. While you're an adult or a very, very experienced pharmacist, obviously, when you communicate with an adolescent, it would need to be in a different approach because they need to find themselves relatable to the way that you communicate you need to be kinder, you need to be specific in the words that you use, not to scare them away, because remember, they've got the ability to look at you as their mom one way, or look at you as the healthcare worker the other way, or look at you as their peer or friend. That's the other way to consider you. So if they've got a mother, they've got a healthcare worker, or they've got a peer, who are they most likely to listen to? The peer, rather. So that is the reason why you would need to know which type of languages they're using right now, what is trending amongst the adolescents. And then there's the general prevention strategies, like advising women, drink water. And also, when you say drink water, so drink water would be applicable to women that have got access to clean water. But then if a woman does not have access to clean water, let's say they're living in a developing country where clean water is more of a privilege rather than an accessible resource, then you need to adapt your health promotion strategy to tell them how to clean the water. Another way is managing stress, because women deal with a lot of stress. But then you need to ask yourself, is it possible to manage stress? For example, right now there is instability in Afghanistan. We had an earthquake in Haiti, for example. How do you approach a woman that is located in Kabul and tell them manage stress? So those are the types of things that you need to consider depending on the location that you are in. And then there's eating a healthy diet. But then remember that for a woman, they will ask you, what is a healthy diet? There are multiple diets going around right now. There's the paleo, there's the fruitarian diets, there's the vegan diets, and so on. So which one is available? Which one would work? So that is where you come in. And then maintaining a healthy weight, whether the woman is overweight or underweight, how do they manage their weight? And also social exposures, like don't smoke and limit alcohol. But then unfortunately, there are women that still use fire to cook with. And using fire to cook with exposes them to unsafe fumes. So when they're exposed to unsafe fumes, that results in these women not being exposed to respiratory diseases and so on. How do you deal with such things, and how do you educate the women to empower them towards self-care? So in terms of providing information and advice, you as a pharmacist in the community pharmacy, you need to make yourself available to the women that you have within your pharmacy, and also the women that you have within the community. And by community, I mean that don't wait for women to come into the pharmacy to seek advice. You can go to the women and provide the advice through engaging with different organizations that support women and so on. You need to be able to read in between the lines and use nonverbal communication. So when you've got a woman that comes into your pharmacy, they want to be heard. They've got concerns. Sometimes they will not tell you all their problems, but then because you're a good pharmacist, you need to be able to detect whatever messages that are hidden that they're trying to communicate to you. You need to be able to provide your patients with health and medicine information. That is both to patients within the pharmacy and also outside of the pharmacy. And the one thing that you always need to do is make sure that you translate whatever health information you have available to yourself that you feel might be useful to your patients or might be useful to your to the community. You need to be able to translate this information so that the women understand, and you can empower them to engage more in their own self-care. By translating this information, you can make it available on social media platforms or also within the community when you engage with them. In terms of providing psychosocial support, Well, you would say that as a pharmacist, psychosocial support is not your duty, because we've got psychologists, we've got psychotherapists, and we've got psychiatrists within the healthcare system. However, remember that as a pharmacist, you are the one person whom women or patients will always come to before they actually see their medical practitioner. So, and when you're a pharmacist, you need to be able to identify the needs that the women have in your community. For example, in my community, we have got a problem with gender-based violence. So whatever strategies that I want to do to empower women towards self-care, I need to be able to relate to gender-based violence. If, for example, within your reach, you might be dealing with poverty, you might be dealing with a cancer burden or many other disease burdens or cardiovascular conditions. So when you are making up strategies to empower women towards self-care, you need to include the needs that you would have identified into your interventions. And then you need to provide training for your staff within the pharmacy. You need to empower your staff within the pharmacy to be able to transfer the empowerment towards self-care to your patients and also to the community. You need to be able to facilitate open communication with the patients that you have within your pharmacy, and also have open communication whenever you are engaging with the community at large. So in conclusion, women have got unique healthcare needs than what men would have. As it was clearly stated, and it's always repeated, that pharmacists are the most accessible healthcare providers within the healthcare network. We're in the best position to empower and promote self-care amongst women from all walks of life. So we took an oath to care for women. We took an oath to care for humanity and also to advance the well-being of humanity. So we always need to make the difference wherever we are. Thank you so much. And thank you for being a good audience to the presentation.
Thank you so much, Nsovo, for a very interesting presentation. And I'm sure that we will get some questions that we can discuss in the panel discussion about the role of the pharmacist in this respect, and the importance of empowering women also to be able to take better care of themselves, and particularly interesting the psychological aspect, which is so important and becoming increasingly more and more so. Thank you very much. So let us move to the second presentation. We have Gail Anderson. So Gail Anderson is an advanced pharmacist practitioner working within women's health in the NHS Grampian in Scotland. She currently practices in a small district journal hospital situated on the Moray coast in the northeast of Scotland. Currently, she is working within a small but innovative clinical pharmacy team, which has received international acclamation and national awards for some of the work that has been presented. She's deeply passionate about improving healthcare and enabling informed decision-making within the female population. She deems important to ensure that evidence-based medicine is at the heart of decision-making, and that the woman is fully informed and consulted regarding the benefits and risks of treatment or no treatment. Her main area of expertise is prescribing in pregnancy and breastfeeding, ensuring that the breastfeeding journey is protected and prescribing is safe and effective. Recently, she has been involved in research and development of a self-referral nausea and vomiting in pregnancy clinic within the antenatal ward. This work is still ongoing. It is also important that she is able to share her knowledge with the wider healthcare teams and regularly take part in teaching within the hospital, and she hopes to take this further into the community setting in the near future. This is why she's grateful for the opportunity to share some of her knowledge and information via this webinar. And now, Gail, the floor is yours. Thank you very much.
So, hi, thank you very much for that lovely introduction. My name is Gail, and I am recently have taken up the job in women's health in my area. Looking at women's health as a whole, we have huge issues with data and the issues around clinical trials, and not as a rule involving women in these clinical trials. So having looked at the population as a whole, women tend to make up around 50% of the population. It's around 49.6% at the moment. And within this 50%, 55.5% of the women are of childbearing age. Apologies, I'm a wee bit fast on my slides, Chris. Sorry, I'm on the gender data gap one. Fabulous, thank you. So looking at the gender data gap, most medications tend to be unlicensed in pregnancy and breastfeeding. This is primarily due to the fact that it is unethical to carry out clinical trials in these cohorts. And because they're not included in the clinical trials, they're then not included in the license submission. This does not mean that these medications are unsafe. And the flip side of that is that it doesn't necessarily mean that they are safe either. But there are many specialist resources available that can be consulted when you are advising on medications in pregnancy and breastfeeding. And it's hugely important that women are given this information and that they are allowed to make robust, evidence-based, informed decisions for themselves regarding their healthcare and the health of their children as well. So making informed decisions is all about making sure that you are making the women available, making available accurate and up-to-date information. And it is not about giving advice. Advice is personal. Information is data. It is important that you do not inflict any of your beliefs on these women when you're enabling them to make informed decisions. And it is about providing support to enable the parents and the patients to make their informed decisions. So making sure that it's translated into understandable language and that we're not just giving them scientific information that they are potentially unable to understand. So the number of women requiring medication in pregnancy and breastfeeding is on the increase, primarily due to an increased age in pregnancy, the number of pre-existing conditions, and then we've got obstetric complications that can occur as well. It's essential that women can make robust and informed decisions about their medication in pregnancy and breastfeeding. So firstly, looking at pregnancy, your potential harms include spontaneous abortion, potentially from the use of isotretinoin, for example. Prematurity can be caused by statins, and we are all very aware of the issues of impaired neurodevelopment with sodium valproate. So looking at how medications can cause an issue in pregnancy, drugs mostly cross the placenta via diffusion, and the extent of this diffusion depends on many things, including molecular weight, their ionization, protein binding, and lipid solubility. So looking at reducing risk, we're looking for non-pharmacological options, considering which trimester they're in, avoiding known teratogens, avoiding newer drugs because we simply don't have the data on them, trying hard to avoid polypharmacy as increased numbers of drugs will cause increased issues, and as we always try to do, using the lowest effective dose for the lowest time required. So looking at some really common ailments in pregnancy that you are very likely to come across in the pharmacy, we're going to have a look at the following. So nausea and vomiting, pelvic pain, weight gain in pregnancy, hemorrhoids, constipation, gastroesophageal reflux disease, and finally vaginal candidiasis. So nausea and vomiting in pregnancy, this is something I have been working on quite in depth of late, and have realised that it is a huge issue in early pregnancy, potentially going on further, and in some women does not go away until delivery of their child. So looking at approximately 70% of pregnancies being affected by nausea and vomiting. Obviously, this comes in different severities. Some patients will have huge issues, and the next one will have a couple of days where they feel a little bit on the off side. The cause is unknown, as is the problem in a lot of women's health, is there's just not the research being done. However, there is some research being conducted now. One of the most important things is to realise that it's not limited to mornings. Colloquially, we have called it morning sickness. However, it can happen at any time of the day. So the important things for you to discuss with women if they appear with regards to having issues with nausea and vomiting is to ensure that they are eating and drinking little and often. A little of anything is better than nothing at all. So we wouldn't be overly concerned about the types of things that they are eating or drinking. It is simply about ensuring that they are not becoming dehydrated or that they are struggling with nutrition. Some women tend to find that there are specific triggers of their nausea. It can be really helpful to keep a daily diary of their food and fluid intake. One, to make sure that they are getting enough, but also they can help to identify triggers. For example, if they were to eat a cheese sandwich and then they felt particularly ill after that, then potentially something in that sandwich has caused a trigger. If nausea and vomiting is interfering with daily life, medication may be prescribed for this. Different countries will have different policies for this, but we are aware that there are safe drugs for use for this purpose, and it is just about ensuring that the woman is completely informed with regards to issues that may arise, side effects, the increased risk of cleft palate and cleft lip with ondansetron, for example, and this allows the woman to make the best decision for her. Looking at severe nausea and vomiting, we have a condition called hyperemesis gravidarum. I see quite a lot of patients who turn up at the hospital requiring fluid resuscitation, have lost more than 5% of their weight when they were booked in for their pregnancy. And this can cause huge upset, can cause the women to have depressive episodes, and can sometimes lead to termination of the pregnancy if the woman is unable to cope with the ongoing vomiting, nausea, and all that that brings with it. We have a great site in the UK called Pregnancy Sickness Support, and there's wonderful information on there, and there are also lots and lots of leaflets that can be printed out. So looking on to pelvic girdle pain, pelvic girdle pain tends to happen slightly further on in the pregnancy, but can happen at any point. The most obvious symptoms of this are pain on walking, going up and down stairs, standing on one leg, turning over in bed, and if you're moving your legs apart, for example, trying to get in and out of motor vehicles, so that can be really tricky. So the pain primarily sits over the pubic bone, roughly level with your hips, and it can cause significant pain on day-to-day tasks, getting out of bed, getting up over the sofa, going to the bathroom. It can be very debilitating. So can be across one side or both sides of your lower back. Obviously, we would be checking for red flag signs, for example, loss of continence, pain running down the legs. The pain can also occur between the vagina and the anus, and occasionally the pain can be found spread into the thigh areas. So with regards to advising on self-help for pelvic girdle pain, TENS machines can be really helpful. You just have to make sure that you're not going to place them on areas of the body where you could potentially stimulate labour. Simple analgesia, absolutely fine in pregnancy. So looking at paracetamol, non-steroidal anti-inflammatories are not recommended in pregnancy. In the UK, we are able to self-refer to physiotherapy, and if you are pregnant, then you tend to be a higher priority and go up the waiting list. So exercises and water, swimming can be really good for this. Obviously light swimming and not doing anything that involves moving your legs around too much, particularly opening your legs. So things like gentle exercises in water, having a bath, those kinds of things can really help. I mean, the majority of this is non-pharmacological. I'm sure you'll appreciate that we are trying to use drugs as little as is physically possible in pregnancy, particularly in the first trimester. But a lot of these things are really, really helpful. A supportive pillow, for example, when sleeping at night. So having a pillow that is placed between your knees, sleeping on your left-hand side, making sure that you're rested. If someone else can do something for you, then that's really helpful. And going up the stairs backwards just uses slightly different muscles. So it can be a strange one when you recommend that to people, but it certainly does have its advantages. Also, walking aids, for example, crutches, and also maternity support belts can be incredibly helpful for pelvic girdle pain. So weight gain, weight gain varies greatly in pregnancy, and there is kind of a normal healthy weight gain of between around 10 to 12.5 kilos. Most of this occurs after 20 weeks and is due to the baby in the placenta. So it's only expected that there will be weight gain in pregnancy. The body is also storing fat, and this helps with the production of breast milk. Unfortunately, too much weight gain can affect the woman's health. It can interfere and cause complications. It can interfere with vaginal birthing, and can also lead to increased blood pressures and the risk of preeclampsia and gestational diabetes. On the flip side of that, gaining too little weight can cause issues such as premature birth and intrauterine growth retardation, which can result in a low birth weight baby. So staying active is important whilst pregnant, and it also helps with preparation of labour and birth. So if you are regularly active, there is nothing to say that you can't continue that activity or exercise, unless you have been advised by your healthcare provider that this is not recommended. So maintaining a healthy diet and maintaining your exercise levels are super helpful for weight gain purposes in pregnancy. Okay, moving on to hemorrhoids. Hemorrhoids, again, really common in pregnancy, particularly caused by progesterone, causing the walls of your blood vessels to relax and expand. The fetus growing, obviously it's constantly growing, getting heavier, and the weight is putting pressure on the surrounding areas. So symptoms, I'm sure you're aware, are itching, aching, swelling around the bottom, pain and bright red blood on passing stools, and if on touch, there potentially could be a lump hanging outside of the anus. So another cause could be constipation. So making sure that you're keeping your stools soft by eating regular fibre and drinking plenty of water. It's important to note from a pharmacy perspective that the licenses for the over-the-counter preparations differ. So it might be that one is licensed in pregnancy and the next one says that it is only supervision of a midwife or doctor. I myself, as a healthcare professional with an expertise in this area, would be more than comfortable prescribing off license. But again, the woman has to be informed about risks and benefits, and this is taken into consideration. So looking further at constipation, constipation is hugely common in pregnancy. So we're looking at just normal, everyday constipation advice that you would give to non-pregnant patients. So making sure that they are including enough dietary fibre, their fluid intake is adequate, and they're maintaining some kind of activity. Only if these measures are ineffective, then we would be looking at offering oral laxatives, and it would be short term with the hope that that would be enough to get things going. So first line in the UK is a bulk forming laxative. So something, for example, as Espagula husk. If this doesn't work, then we're looking at changing to an osmotic laxative, and our first choice there would be lactulose, but we could potentially use one of the macrogols. And then if stools are still difficult to pass, or we're struggling with incomplete emptying, then a short course of stimulants such as Senna can be discussed with the woman, although there could be concerns about premature labour if that was to be used. So, and if we're still having issues, then glycerin suppositories can be used, but potentially I would have referred to another healthcare professional for some advice or for help. So reflux, heartburn and indigestion, again, symptoms common from 27 weeks onwards due to hormonal changes, the growing child, the growing uterus, and the muscles relaxing and therefore allowing the stomach acid to come up the way rather than being retained in the stomach. So changes to diet and lifestyle may be enough to control the symptoms, and these are the same as in non-pregnant people. So eating little and often, trying not to eat too close to going to bed, reducing caffeine, rich, spicy, fatty foods, anything that you find as a trigger. Pharmacological treatments, first line would be your alginates, which create a raft to prevent the stomach acid coming back up the esophagus. And proton pump inhibitors have also been shown to be safe in pregnancy, and some of these products are licensed for over-the-counter use in pregnancy. So moving on to vaginal candidiasis, again, common due to physiological changes in pregnancy. So normal symptoms, white discharge, usually without a scent, itching, irritation around the vagina and the vulva, soreness, stinging during sex or urination, and potentially some erythema and swelling. This is more common in the third trimester because of the huge surge in hormones. And whilst there's no evidence to suggest that untreated thrush can cause harm to an unborn baby, if it is present during birth, it can be transmitted, but this is easily treatable. So again, the woman can be informed of all these facts and decide whether the treatment is right for her or whether she would rather wait. Pharmacologically, we are using pessaries, clotrimazole pessaries, 500 milligrams at night, and it's important to note that this is for 5 days and not just for one, and that the prolonged treatment course is required. So if you are seeing a prescription coming in for these pessaries and it is only for one, then potentially you're going to need to question that with the prescriber. A hugely important counselling point is that the applicator should not be used with the pessary in pregnancy, and the pessary should be inserted by the woman using her fingers. So moving on to breastfeeding and how we can support women and why breastfeeding is important as a self-care issue. So breastfeeding prevents illnesses and it saves costs and treatment. And for those purposes, in my mind, breastfeeding should be a public health priority. If we can work together in healthcare, including the entire multidisciplinary team, as well as the women, and we can support them in reaching their breastfeeding goals, then we will increase breastfeeding rates. So we often talk about the benefits of breastfeeding, but I sometimes wonder if people are fully aware and informed of the benefits of breastfeeding. So the health impact for the child in of itself is huge. We've got a reduced risk of infections, including gastroenteritis, lower respiratory tract infections, UTIs. If we're looking at premature babies, breast milk is seen as a medicine as opposed to a food, because it can reduce the risk of necrotizing enterocolitis, which carries a very high mortality rate. Looking into the future, you're reducing risks of diabetes, hypertension, obesity, impaired central nervous system. There's recently been evidence to suggest we're reducing childhood leukemia, and well known, there is a reduced risk of sudden infant death syndrome. So all in all, it makes a huge difference. But often we talk about the benefits of breastfeeding as opposed to the risks of formula feeding. So these are not necessarily benefits of breastfeeding, but you take these benefits away if you don't breastfeed, if that makes sense. So looking at the health impact for the mother, reduced risk of ovarian and breast cancer. Recent data has shown that if the woman is BRCA1 and BRCA2 positive, that breastfeeding for a year has the same protective effect as hormonal treatment. And for the longer that the woman breastfeeds, the lower the risk of ovarian and breast cancer. And this can be in one breastfeeding episode, or it can be in multiple breastfeeding episodes with different children. We're reducing the risk of hip fractures, postnatal depression, cardiovascular disease, type 2 diabetes. We're reducing the incidence of obesity as women go back to pre-birth weight quicker. And we also increase the pregnancy interval, which is shown to reduce premature birthing, associated obstetric issues such as placenta accreta, where the placenta grows too far into the uterine wall. So these things are massively important with regards to self-care. Issues associated with cessation of breastfeeding. So if we regularly recommend to a woman that, oh no, you can't breastfeed on this medication without fully researching it, potentially the baby won't take a bottle. It's not as easy as switching a baby to a bottle. The baby may reject the bottle, and I've heard clinicians say, well, they'll take a bottle when they're hungry. It doesn't necessarily work like that. Breast milk it's not a tap, so you can't just stop breastfeeding for a week. That in of itself comes with issues. For example, increased incidence of mastitis and breast abscesses. So we have to inform the mum, if she does have to stop feeding for a period of time, how can she maintain her supply if that's what she wants to do? How can she re-establish her supply further down the line? But also, how can she safely reduce her supply and reduce her risk of getting mastitis or breast abscesses? The other thing to think about is socioeconomic factors. So the cost of formula, the cost of breast pumps, the cost of bottles, sterilisers, the time associated with all this increased work. So there's a lot of information that needs to be given to the mother, and there's a lot of factors that need to be considered when we are advising on medications and breastfeeding. So this is a World Health Organization slide. So looking, just essentially giving you the information that I've already given you, but along with the information that if we were to improve breastfeeding rates to approximately 40% increase, then we would be saving £50 million a year in the NHS. And that would be on treatment of infections, cancers, medications for diabetes, that kind of thing. And it's also shown that breastfed babies have 15% fewer GP consultations in the first 6 months of life. So again, cost saving as well as beneficial to health. So the current World Health Organization recommendations are that we initiate breastfeeding within 1 hour of birth, and this is to do with stimulation of the lactation process. And the exclusive breastfeeding continues for at least 6 months, and at that point we would introduce complementary foods. However, in the UK, we tend to start off with reasonable breastfeeding rates, usually in the 60%, but you can actually see on the next slide, Chris, please. Thank you. You can see from my slide and the information detailed on there. So these were taken from our infant feeding questionnaires, that there's a huge drop off, sometimes of around 50%. At the 6 to 8 weeks after birth. So what are the reasons that women are stopping breastfeeding by the time they're seeing a healthcare professional at 6 to 8 weeks? The reasons given are lack of support, social stigma, so feeding in public, lack of knowledge from people who they are turning to for help. And in every single one of these bubbles, healthcare professionals are mentioned. So lack of support from healthcare professionals. Oh, well, you've done a good job. Why don't you just give some formula now? Or, for example, if someone is feeding their child and doing natural term weaning, where they let the child decide when they want to stop breastfeeding, you can have healthcare professionals discussing that, is your baby not too old to feed now? The huge one is the lack.
I'm sorry, we're running a little bit short on time, so I would ask you to...
Okay, so what I'll do is I'll skip to what's important, okay, and how drugs end up in breast milk. So you're looking at the ingestion of the medication being absorbed into the maternal plasma, filtration of this through the breast and into the milk. During filtration, drugs in the bloodstream then diffuse into the milk. This depends on the size of the drug, the molecule, and its ability to diffuse across the membrane. The direction of diffusion of the drug is dependent on the concentration gradient, and the drug is excreted from the plasma. It diffuses back into the membrane, again, across the diffusion gradient and back into the plasma. This is just a slide to show how the passage of drugs can occur in the first few days, as opposed to slightly further down the line. The cells close together, and therefore diffusion is not the only factor that we are considering. Can you jump ahead 2 slides, Chris, please? So it's really important that we look at relevant infant doses, and that's a calculation. The half-life of medication, generally the shorter the half-life, the safer the drug is. The milk plasma ratio, so the concentration of the drug in the mother's milk is divided by the concentration of the mother's plasma, and generally the lower this number, the better. The molecular weight of the drug, so the higher the molecular weight of the drug, the less likely it is to be able to diffuse across the membrane. Protein binding, the higher bound the drug is to proteins, the less circulating availability there is in the bloodstream, therefore the less can get into the milk. The oral bioavailability, so as a rule, if something is parenterally administered, for example, gentamicin, then you would not be overly concerned about it, because even if the child does ingest it, it won't be available to them. Is the drug licensed in pediatrics? Generally, as a rule, if it's licensed in pediatrics, it will be safe in breastfeeding. But the most important thing to consider is, what are the risks of not treating? Is the mother going to become unwell, for example? So my final slide is on the COVID vaccination, where pregnant women were excluded from the clinical trials, as they are in most medical research. And this was defended with the argument that they're protecting the mother and the fetus. But this only makes sense if we live in a world where pregnant women never get ill and breastfeeding women never get ill. In fact, the results in pregnant and breastfeeding women using untested medications out with the relative safety of a clinical trial means that they are then having to make decisions based on limited or no information. And at the moment, in the end of May, we had 58% of women declining taking vaccination because they were waiting for more safety data. So my question to you is, how many women have been harmed through exclusion of these patient cohorts in clinical trials? These are just some resources, or do you not got this? Yeah, some resources that are available for safety in drugs and breastfeeding. And that's the end of my presentation. Apologies for rushing through. I'm very passionate and can get very carried away.
Thank you very much, Gail. We completely understand. Thank you so much for your interesting presentation. And I'm sure, well, we already have a few questions which we will take on the panel discussion. Let me now introduce Dr. Safira Hussaini. Safira is Senior Pharmacy Research Manager at Peter MacCallum Cancer Centre in Melbourne, Australia, and Adjunct Senior Lecturer at Monash University. Recognized as the National Pharmacy Expert in Emergency Contraception, Safira is Chief Investigator on the NHMRC Centre for Research Excellence, Sphere and Medical Research Future Fund Alliance trial to expand pharmacists' scope of practice in contraceptive service provision. She will present us a case study on contraception. So thank you very much, Safira, and the floor is yours.
Thank you so much, Emma, to Chris, Lars, Ake, and the whole team for inviting me to speak today. I loved the previous presentations, and two quotes that I will take home with me are that women go through trauma, they are vulnerable in nature, and they have untold stories, very powerful, and that breastfeeding is not a tap. And as I was listening to Gail's presentation, I started to get phantom symptoms of when I was pregnant. So with that, I will begin my case study on contraception. I'll do an introduction to the status of contraception using the 7 pillars of self-care framework, which I understand has been presented in previous webinars. So I won't be going through that in detail, but just to use this as a reference and remind you of what those 7 pillars are. You can see them on the slide there. And I'll just step through them very quickly. Knowledge and health literacy, mental well-being, which also includes self-awareness and agency, physical activity, healthy eating, risk avoidance, good hygiene, and rational use of products and services. The case study that I'll be going through will cover the 3 pillars shown here: knowledge and health literacy, mental well-being, and rational use of products and services. So to just give you a little bit of an idea of where contraception is at worldwide and why it's so important, contraception is a very self-empowering tool that we have, and it enables people to make informed choices about their sexual and reproductive health, which in turn has multiple benefits to a woman, to the users, and to society. According to 2017 estimates, around 214 million women of reproductive age is defined as 15 to 49 years of age. These women in developing regions want to avoid a pregnancy, and they are not using a modern contraceptive method. So that's an astounding number. And if all of women's contraceptive needs were met in the world, we would avert around 67 million pregnancies worldwide. Use of modern contraceptives in 2017 prevented an estimated 308 million unintended pregnancies. So you can see that contraception is a very a powerful tool, as I mentioned, and it is very cost-effective investment in the future of a country. The prevalence of contraception, you can have a look at this graph on the right, and if you follow the black line, this shows us the worldwide prevalence at 2017. It was roughly 63% of married or in union women of reproductive age using some form of contraception. Most of them were using modern methods and only 5% were using traditional methods. So traditional methods are on the decline. And what I mean by traditional methods, this includes natural family planning methods or fertility awareness methods. In Africa, the contraceptive prevalence is expected to reach around 45% by 2030. It's currently sitting at around 36% compared to Oceania, which is around 58%, and the highest being in Northern America, Latin America, and the Caribbean at 75%. There is a global unmet need for contraception. At least 1 in 10 married or in union women in most regions of the world have an unmet need. This is roughly around 12%. So again, if we follow that black line, at 2017, it shows that it's around 12%. We compare this to Africa, where it's shown in the red line, it's around 22%, and Oceania, with the pink line, about 15%, compared to other regions where it's around 10% or even lower. Sub-Saharan African women and Southern Asian women make up about 57% of women with an unmet need, which is no surprise. So the promotion of family planning and ensuring access to preferred contraceptive methods, it's all about choice, and widening the choice is very essential to securing the well-being and autonomy of women. The UN estimates that for every $1 spent on contraception, $2 to $6 can be saved from reduced numbers of people needing other services, such as vaccination or sanitization and other healthcare services. The benefits of using contraception and family planning are shown here. So it prevents maternal morbidity and mortality. And if a woman has access to contraception and can use it well, then you can reduce the number of births. And what we want to do is try and get that down to 4 births, no more than 4 births, and all under the age of 35 years of age. And also, if we reduce the space between pregnancies, that's called the interpregnancy interval, that can also reduce the risk hugely. Reducing unsafe abortion from unintended pregnancies. They're also called in Australia backyard abortions, which are performed unsafely by untrained individuals. Reducing newborn and infant mortality. We know that newborns and infants born to mothers who didn't want to have the pregnancy are usually born preterm, or they have a reduced birth weight. Helping to prevent HIV or AIDS. Nausea touched on this in great deal in her presentation. These people who do have HIV or AIDS have greater reproductive health needs and have a greater need for information that's accessible. Empowering people and enhancing education. This has been talked about again greatly by Nausea, and how you can, by giving them information, you arm them with the knowledge and they can make health decisions for themselves. Reducing adolescent pregnancies. We know that the teenage pregnancy rate, unwanted pregnancy rate in many countries is quite high. And surprisingly, in Australia, it's in the top 3 of developed countries. And finally, it contributes to economic growth. So if you have access to contraception and you're able to avert pregnancies, you're able to participate in society and the workforce, and therefore you reduce the number of dependents to income earners. So achieving universal access seems like a dream, a global dream, including the realization of sexual and reproductive health services. It is essential to fulfill the pledge of the 2030 Agenda for Sustainable Development that no one will be left behind. Now, this agenda, you may be aware, follows up on the Millennium Development Goals. The Millennium Development Goals for maternal, newborn and child health and for reproductive health were not met. And therefore, this agenda was formed to continue that mission. And alongside that, what's advocated for is intensified support for contraceptive services, and also included in that is ensuring that the access points are widened. So if women cannot access a contraceptive from one provider, they should be able to access it from another provider. Having government policies and programs, including our local pharmacy policies supportive of those movements, and invested in upskilling health professionals and incentivizing them to get trained. New contraceptive technologies. I attended an Australian conference earlier today, and they were speaking about digital health technologies and apps that women can use. Implementation research to expand access and strengthen service delivery. That's all about improving our health services, the quality of information that's provided, the reach to different populations and people who are very vulnerable, including adolescents. Task shifting and task sharing. This is very important for pharmacy, where often the general practitioners or doctors are left to do most of the weightlifting in this area, and pharmacists can certainly become upskilled and take on this task in greater depth and scope. So that's all very good, but unfortunately the current global reality is starkly different to what I've talked about in terms of what our dream and our aspiration should be in this area. So you are probably very well aware of what's happened in Texas with the Heartbeat Act enacted. And it's very, it's such a backward step for women in the country, in the state of Texas, where if anyone is seen to be providing an abortion or facilitating access to an abortion, a civil lawsuit can be filed against them. And this is from any point from 6 weeks gestation, where a heartbeat can be detected. And this is one of the news items that appeared in terms of impact that this sort of legislation is having on women, or could have. These are some protesters, pro-life protesters. And to prevent this sort of thing happening in Australia, we have introduced what's called safe access zones. So in these safe access zones, women and healthcare providers who are accessing and providing abortion, respectively, should be able to access this safely, because abortion is healthcare. And filming women or providers protesting against what they're doing, picketing, all of this is banned in these safe access zones. And yet, whilst that's all very well and good, we have articles such as the following, estimating the Australian abortion rate, with such a visual infographic accompanying the article happening at the same time. So all of this has to change. The messaging that happens has to change. So I'm going to move on to the case study now. We have Arushi Kumar. She identifies as a she or her, and she presents to a community pharmacy. She's a 20-year-old female. She's an international university student living in Melbourne. She's studying a Bachelor of Accounting, and she requests emergency contraception. So looking at the Australian population level data, around 1 in 4 women have had an unplanned pregnancy in the last 10 years, and 56.6% who have had unintended pregnancies were not using contraception. So there are still some evidence practice gaps there that we need to solve. We need to find out, why are women not using contraception? Is it an access problem? Is it a knowledge problem? Or is it a combination? So the highest risk of unintended pregnancy are those women who, interestingly, have increased age. So in one of these studies we did, we found that women who were 25 to 34 had a higher chance of having an unintended pregnancy than those who were younger. Those who come from a non-English speaking background, who identify as Indigenous or Aboriginal. Those who hold a healthcare card where they can have subsidised healthcare access, or those who have 3 or more pregnancies had a higher risk. Arushi doesn't appear to meet these criteria. Perhaps she may be from a non-English speaking background, but in all likelihood, she probably can speak very good English. So she tells you that she had unprotected sex around 6 hours ago. Her and her partner didn't use any contraception. Interestingly, she met her partner on a fitness dating app called Fitify. It's a very common occurrence now, especially in COVID times. And they moved in together a year ago when the pandemic started. She's not taking any regular medications. However, she does get occasional tension headaches when studying for prolonged periods of time when she takes ibuprofen at a standard dose. She has no known allergies and her BMI appears to be healthy. Now, she's very knowledgeable and she knew that emergency contraception, or EC, is available over the counter without a prescription from pharmacies. And our research has shown that a lot of women actually don't know that it's available still from pharmacies, and many do still go to the doctor first. She doesn't know how it works and what side effects to expect, and she has never used regular hormonal contraception before. Her partner prefers using barrier method, mainly condoms. So the one key question that you could ask Arushi, or you do ask Arushi, is would you like to become pregnant in the next year? This is a really good question to ask as a screening question to work out what someone's pregnancy intentions are. And Arushi says no. So looking at this flow chart of what could happen in response to that question, if a woman says yes, then you can conduct some preconception care screening. If she says no, then you can provide some information about her contraceptive options. And if she's not sure, then you can plan for pregnancy, but you can refer her to a family planning provider or physician as needed. So looking at emergency contraception and what options are available in Australia, we have oral hormonal emergency contraceptives that delay or inhibit ovulation before the luteinizing hormone surge occurs. These don't work if taken after the surge or if after ovulation has occurred. So we have levonorgestrel and allopurinol acetate here. Importantly, allopurinol acetate is still effective if taken after the surge, but it has to be before that peak. And neither, importantly, prevent implantation of a fertilized egg nor abortion of an existing pregnancy. This is a very important point because we found that this is a knowledge gap in pharmacists' understanding of how it works. We also have the copper IUD. Now, in interest of time, I will skip over this table a little bit. I'm just going to highlight the 3 different emergency contraceptive methods, some key points. 2 of them are oral forms, allopurinol acetate and levonorgestrel. The copper IUD is, as it suggests, an IUD. They have different timeframes for use in terms of effectiveness. The copper IUD is the highest in effectiveness, followed by allopurinol acetate, followed by levonorgestrel. So which one to recommend? The timing, it depends on the timing. So if the unprotected sex episode has occurred at or after 72 hours and the person wants oral EC, then allopurinol acetate is the only one with proven efficacy. However, in Australia, we have a barrier here to access. Not many pharmacies stock it. And we are trying to work out why that barrier is in place, despite it being more efficacious. If there's a chance that ovulation has occurred, then the copper IUD is the only effective method. Risk of further unprotected sex and pregnancy. So if there's a delay in commencing ongoing contraception, hormonal contraception cannot be commenced within 5 days of allopurinol acetate, but it can be started immediately with levonorgestrel. So that is an advantage of levonorgestrel. If the person has a high BMI, allopurinol acetate or the copper IUD are preferred. And if the person's using enzyme-inducing medicines, such as phenobarbital, the best option is copper IUD, but the LNG dose can be doubled to 3 milligrams. And it's important to note that if a woman is referred for a copper IUD, then you have to give her oral EC at the same time of referral in case she changes her mind or she can't get that copper IUD inserted. And again, there are barriers to insertion, such as availability of skilled inserters. This is a decision aid, which is an EC wheel that is freely available to anybody. It's a fantastic counseling tool, and I recommend that you access it and have a go at using it. The wheel spins depending on what criteria the woman meets or doesn't meet. And there are versions in English and in French as well. So which one for Arushi? If you go to the tool and you look at all the things that she's told you, She is suitable to have allopurinol acetate if she so desires, if not levonorgestrel. So the type of information you should give her should be done in such a way that it's confidential, it's private, it's done with dignity, it's non-judgmental. You can also offer her information on what her ongoing contraceptive options are, about STIs and how to get tested, need for review by a general practitioner if her period is delayed after taking EC, and what she should do if EC is not successful, because there is a chance that it may not be successful, and if pregnancy occurs. If she has unprotected sex after taking EC, it does not stop her from becoming pregnant. Her next period is probably going to be on time, but it could be earlier or later, and she can perform a pregnancy test if this does happen. And if she hasn't commenced a long-term contraceptive method, it's important to use a barrier method until her next period. You can also counsel her on the usual aspects of dose, effectiveness, and side effects. In terms of regular contraceptive options, she comes back later to the pharmacy and she wants to know more. However, her partner isn't keen for her to start regular contraception because he believes that it can affect future fertility. So she wants more information on this aspect before seeing a GP. So we have to exclude reproductive coercion here if possible, and Nausea touched on this, that it does occur, and there are some clear trends, although early, emerging in Australia. 1 in 7 women are affected, 1 in 5 women from culturally and linguistically diverse backgrounds, and Aboriginal, Torres Strait Islander backgrounds, and up to 60% in their 20s. So Arushi could meet this criteria, but we would have to explore that further with her. And this may or may not be the time to do it. It depends, because often people are in a rush when they're coming in to get EC, and it is a vulnerable time point. So looking quickly at the efficacy of contraceptive options in Australia, we have the natural methods, family planning methods down the bottom, the barrier methods. In between, we have some hormonal methods such as the pill, the ring, the injection. And then up the top, we have sterilization methods and implant and long-acting reversible contraception. This is pretty much the same thing reiterated, and that the perfect use rates and the typical use rates start to match each other when you start using things like long-acting reversible contraception. And that's what you want. You want people to be able to use these reliably and consistently. Very quickly, if I have 1 minute, I'll just go through these contraceptive decision aids. These are used to facilitate shared decision-making. They're fantastic. And I'd like to skip to the next slide to show one in particular that I really like. It's freely available from the WHO. It comes in a flip chart format. If you print it off, you can keep it in your pharmacy, and you can use it to step through counselling and preferences for the delivery of information with a woman. So to answer her question about future fertility, or her partner's question, IUDs or implants, the fertility usually returns. That's why they're called long-acting reversible contraceptives. The injection, the dextromethorphan acetate injection, it's variable, but it's expected that 65% of women who wish to conceive can do so within the first 12 months. And therefore, LARC, or long-acting reversible contraceptive, may be a less obvious method to others. Therefore, it might be preferenced by Arushi, but ultimately it's up to her. Your job as the community pharmacist to provide her with all the options. So in summary, we have to take a patient-centered approach to counselling. We can use this framework to frame our responses and recognise that healthy and unhealthy behaviours do cluster. So if you're counselling about one behaviour, usually it can affect the other. You can screen for reproductive coercion if it's possible, and if time permitting. And then just a few last points here. Refer women to the doctor for most appropriate contraceptive selection. Try to promote LARCs if possible, because they are first line. And just a summary about the different methods and their advantages and some key practice points. So I'd like to end there. Thank you very much.
Thank you very much, Saphira, for a very interesting presentation. I think that we had a very nice overview of the topic itself. different aspects in terms of what is most important in terms of women's health and what are the more frequent issues, and then a very interesting case study with clear implications for the communication between the healthcare professional and the person, and taking into account not only their needs but also expectations and preferences, and this is really important, and thank you for showing also the very informative tools. So we are a little bit short on time for our panel discussion, but I'm sorry that I wasn't able to be more effective in the chairing of the session. But in fact, some of the questions that were coming through were identified and replied to during the webinar itself. So I think that we may have a couple of questions for the panel discussion, very brief questions. So one participant asks, what is an unmet need? And I think that this is an interesting concept, and one that in which pharmacists may have to be more proactive. What does it mean? And maybe you would all like to comment on it and share what you think the pharmacist's role in an unmet need should be. Let us start with Nusovo.
Thank you, Emma. So an unmet need is, well, needs do exist from our patients. They do need us for whatever various reasons that are available. So an unmet need is when we are unable to reach out to our patients to meet those needs that they may intentionally alert us of, or they would not alert us about. So in the public health perspective, for example, our female patients would need more information about which drugs should I take when I'm on my period and so on. So if me as a pharmacist, I'm unable to provide the medicines which they need and so on, that is an example of an unmet need. So the role of the pharmacist, like I said, is to identify what are the needs of your of the community, what are the needs of the women around you, and then start planning around the strategies on how to meet those needs and also fulfill the needs of the people that are around you that you are supposed to serve. Thank you, Emma.
Thank you very much. Gail, would you have any comments about unmet needs and how the pharmacists can respond to these?
Yeah, I think my obvious unmet need is the lack of data for medicines in women. And obviously we can collect data, we can retrospectively look at safety data as well. And as a pharmacist, we are well placed to translate this into everyday information for patients. So where there may be a lack of data, we are well versed in looking at specialist resources, and we can use those rather than just going with mainstream information.
Thank you very much, Gail. Safira, I don't know if you would like to add on this, but I also have a very specific question for you from a participant. And this is why, what is the reason why BMI is considered in selecting the best contraceptive?
Okay, yes, thank you, Emma. I'd like to add about the unmet needs. I think Nusovo and Gail have covered it very extensively and well, but just to add, in terms of my own experiences as a woman who has experienced reproductive sabotage in terms of birth control sabotage. So this is a very common thing that can occur, and I have experienced it myself, and I've also gone through trauma in different ways. I have been pregnant twice, so my unmet needs have existed definitely, and my main one was, even though I'm very health literate as a pharmacist and I'm very educated, I still felt I did not get enough information or education from the health professionals that I saw, from the doctors, from the midwives, from the pharmacists, from all the antenatal team about different aspects of what I experienced. So whether it was around symptom management, like all the symptoms that Gail touched on, even physiotherapists I saw. So that was one big thing, information. And the second thing was empathy. This was an unmet need of mine. I didn't get enough empathy from my health professionals. So I would, and I felt very helpless as a result, because I felt like nobody was actively listening, and therefore nobody was able to help me and really truly understand the crux of my problems. Eventually I solved a lot of those problems myself, because they were physiological problems or symptomatic problems, and I researched and I found solutions to them, but it was very painful. So anyway, I just want to share that experience about unmet need. And to answer the question about BMI, the reason why we have to look at BMI is because these emergency contraceptives, their absorption gets affected and the pharmacokinetics get altered when a woman has more body fat. So when she's overweight or when she's obese. So when we look at the definition of overweight or obese, it's usually 27 and above. So if you calculate that to be the case, it is much safer for her to go for a copper IUD if you can refer her to a provider. And this is why it's important for community pharmacists to know who their providers are in their area. Who are the general practitioners who insert? Who are the family planning providers, the sexual health clinics who can do this? Who can you ring up and make that appointment to on her behalf?
Thank you very much, Safiri, and also for sharing your personal history. I think that a lot of us can relate to those difficulties, and I believe that this is so important to share. And it's not only about being able to access the information, it's really about the support and all the context of when we most need a friendly shoulder, and also a professional shoulder that guides us and supports us in this context. And for sure, community pharmacists specifically have a role to play in this respect. Thank you so much for your participation. And let me just wrap up really shortly. Just saying that this, as I've mentioned in the first part of the webinar, this is a series of webinars talking about self-care and different topics. So you are invited to visit our webpage to consult on our agenda. Next time we will be accelerating self-care to achieve universal health coverage. This will be on the 6th of October. And if you scan this data code, you can link directly to the registration, but this is all on our website as well. Please also join us to celebrate World Pharmacists Day on the 25th of September. And again, you can go to our website and be part of the campaign yourself. We invite you to do so and to share on social media. And you can check all our future FIP digital events, and not only those related to self-care, on our website, events.fip.org. Thank you so much again to Reckitt for supporting this online program, and all of you for participating, and our distinguished speakers who really did a wonderful job today talking about women's health. Thank you so much for attending, and see you next time. Thank you.